All right, running and knee injury. Physical activity has many benefits, but in some cases can aid in the progression of painful diseases like osteoarthritis. Previous studies have had mixed results on the relationship of physical activity to the development and progression of osteoarthritis of the knee. Participation in sports at high levels is known to have increased risks of osteoarthritis of lower extremity joints. However, less is known about the role of recreational exercise on osteoarthritis development. Some studies have suggested that long distance running may not be associated with increased progression of knee osteoarthritis in healthier middle to older age runners. It is estimated that 36 million people run in the United States alone. These runners could all be at a greater risk of developing osteoarthritis, the most common joint disorder in the United States. Among adults 60 years of age or older, the prevalence of knee osteoarthritis is approximately 10% in men and 13% in women. The purpose of this study is to evaluate whether the repetitive trauma to joints acquired through long-distance running would accelerate osteoarthritis development in adults above 50. The null hypothesis is that there will be no significant difference in osteoarthritis development between runners and the control group. The research hypothesis is that the runners will see significantly more osteoarthritis development than the control group. Subjects included 45 runners and 53 controls, all above the age of 50. Of the 900 plus runners who met the eligibility criteria, 113 of them, residing within 100 miles of Stanford University, were invited to participate. Bilateral anterior-posterior weight-bearing radiographs of the knees were taken in 1984, 1986, 1989, 1993, 1996, and 2002. All participants provided information by annual self-reported questionnaire on demographics, medical history, BMI, exercise habits, musculoskeletal injuries, and functional status. As running is a form of vigorous exercise, data was collected on all types of vigorous exercises performed, including running, swimming, cycling, aerobic dance exercise, racket sports, and brisk walking. To assess progression of radiographic osteoarthritis, joint space narrowing, sclerosis, and osteophytes were each graded on a scale of 0 to 3. The sum of these scores led to the total knee score, or TKS. Joint space width, or JSW, was determined as the joint width in millimeters of each knee compartment. Chi-square and t-test were used to compare demographic variables, BMI, TKS, JSW, prevalent osteoarthritis, and the number of knees with severe osteoarthritis at the end of the study between the runners and controls. Of the 113 patients in the study, 98, 45 runners, and 53 controls had at least 2 sets of radiographs by the end of nearly 2 decades of gathering data. Runners had decreased their running time by 55% at the end of the follow-up period, but had maintained the time participating in overall vigorous exercise. At the same time, controls had increased the average time spent in other vigorous activities by 100 minutes per week at the final radiograph. The increased non-running exercise for both runners and controls consisted mainly of brisk walking. Total knee scores were worse at the time of initial radiograph in runners compared to controls, 1.29 compared to 0.40 respectively, but were similar in both groups at the end of the study, 3.60 versus 4.21 respectively, reflecting a greater overall progression in control subjects. Similarly, JSW of the worst knee was slightly worse among runners than controls at the initial radiograph, but were nearly identical at the final assessment. While a higher proportion of controls had prevalent osteoarthritis by the final radiograph compared to runners, this difference was not significant. The null hypothesis that there will be no significant difference in osteoarthritis development between runners and the control group could not be rejected.